I'd like to welcome you all to Carotid Question Time. I'd like this to be as interactive and informal as possible. I'd really like you to interact with our panel of experts here. So I'm going to start with one question to the panellists, and I'd like you to provide us with your own questions also. So my first question is to Mark. What do you think it takes to advance carotid artery stenting?
I think that we have some trials going on. I doubt if these trials will have different outcome than the trials that have been performed so far. It will change only if there is a change in the psychology and in the mentality. Now we have a battle endarterectomy against stenting. I think that's a completely wrong perspective. We should look at patient-tailored solutions. There are definitely patients that will benefit better from stenting. There will be definite patients that will benefit from endarterectomy better. We should look in that way. There should not be a battle against one technique or the other. It should be combined. There's enough volume for both techniques, and we should tailor it to the patient, not to the ego or the idea of the physician.
I want to just take that forward. Mike Jaff, you're in the position of referring physician for these procedures, and Mark mentioned the psychology, which is most important for the referring physician. Could you take that forward?
Well, I think the referring physicians in the United States are more confused now than ever about what to do, quite frankly, and who to refer to. I think there's been a lot of hype around this debate between endarterectomy and stent to the point where many of our neurology colleagues have made the case that shouldn't be the debate at all, that medical therapy is all you need to do. And so that further confuses the issue. So it takes a referring doctor who's sitting with a patient who's got in a carotid ultrasound report of a 70 to 89% asymptomatic carotid stenosis, thinking that all they have to do is adjust their statin, and that's all they have to do. And meanwhile, the patient's saying, I don't really know if I want to live with this lesion as it is, so can you get me to somebody who can give me another opinion? And then the doctor says, well, gee, I wonder who I should send you to. If I send you to the surgeon, you'll probably only be told that endarterectomy is the option. If I send you to the interventionist, they'll want to convince you to have a carotid stent. So what should I do? And I think there's so much confusion out there that's the number of consults that I get. It's not necessarily, what should I do for this patient, stent or endarterectomy? It's what should I do, period.
Okay, can you take that forward, Alison? Mark mentioned the trials. He thinks the ongoing trials are not going to give us a different result from the ones that we've had before.
Well, it's difficult to believe that because, of course, the trials like ECST and NASIT, their evidence is now more than 20 years old. Their medical treatment is 20 years old. There were no statins at that time. So even that basic formula that keeps being rehashed of, how many endarterectomies you need to do to prevent one stroke is probably absolutely out of date. And then, of course, the difficulty that you have, or that I would have when a patient comes to see me, is that I can give them good evidence about endarterectomy, but I really can't give them good evidence about stenting because, first of all, you've got a bunch of trials based on people who had very little experience, and then the only recent trial is still too small, big wide confidence intervals. So you can give them good evidence on one, you can give them good evidence on medical treatment, and the thing you really can't give them good evidence on yet is stenting.
Let's just go back to the original question. John, what do you think it takes to advance carotid artery stenting?
Well, I think it's evidence. I just want to respond to Michael's comment. I think that the area where interventionalists dominate carotid stenting is very local and regional specific. In our own area, the neurosurgeons had a long history of endarterectomy, and they do stenting. With my arrival, the vascular surgeons do it, and we've already kind of established the brand name of the vascular surgeons and neurosurgeons as the carotid specialists. So if you look at the SVS data survey in 2006, and more than half of vascular surgeons do more than half their practice endo in 2006. I don't think it's true anymore in many areas of the U.S., at least, that vascular surgeons don't offer carotid stenting. Getting back to the evidence, I think carotid disease is unlike any other field that we encounter here. Venous disease, it's a no-brainer that the minimally invasive is less pain. Thoracic TEVAR, it's a no-brainer. It's less complicated. But carotid disease has always been this want for high-level evidence. I believe it's the most studied procedure in the Western world for surgical treatment, that is carotid endarterectomy. And so to replace it, which I happen to think is going to happen or be displaced in the majority, is going to take a lot of evidence.
Klaus, going back to the technicalities of that, how do you think we can move carotid stenting forwards? What are the current problems with the procedure?
The current problem is we had not enough well-trained people doing the procedure, because many thought, oh, it's so easy to bring up a catheter, and so I can also place a stent, and then it's done. But then we learned, because that's an embolic disease in principle, that there are more adverse events than was expected. That is shown in all the trials. So they underestimated the training you need to do the procedure properly. So we have to train people. That's the first point. Yes, not every cowboy can shoot at the carotid artery. And you have a training for surgery, because before you do your first carotid endarterectomy, you underwent a training process of a couple of years. And with carotid artery stenting, that's unregulated. Everybody can do it. You only need an X-ray equipment and some ego and a catheter, and then you go on. So we have a very mixed population doing this intervention. That is one of the weak points. So we have to look at training of the people and credentialing. So we have to establish some criteria when you should start to do that. And that is certainly different, because in some specialties where you are working quite a lot with catheter techniques, you need certainly less training than when you do very little catheter work and then you start or you begin with the carotid artery. That's one of the points. The other point is you have to build up confidence, at least with your referring physician. So I have lost nearly none of my physicians referring patients because they know all the data. What I recommended from the beginning is have an independent control of your data. We all know that data which are more or less self-reporting are much better than those are independently controlled. And so we show all our patients now for many, many years, before and after treatment, to the neurologist. Naturally, every physician can see if there is a paresis or if the patient has slurred speech or something like that. But this independent control is, I think, a valuable quality criterion. And as I already mentioned, it's building up confidence. So our neurologists refer the symptomatic patients to us. When we say that can be done endovascularly, we treat them. And if not, when we say it's perhaps better to the patient get surgery, then they will contact the surgical department. So the first contact is with us. And that was, yes, built up over 20 years. So I think both of these things has to be considered: training and good contact to your physician, so they are well informed and not only believing what is told in the newspapers or in the TV.
Thanks, Klaus. We've got some people at the back, and there's plenty of seats at the front. Come and join us. There's a question here.
Concerning this problem with the training, I have to tell you that as I see it, in former times, we start with cerebral catheter angiography, which is no more taking place. So we have a lot of experience. We do thousands every day of angiographies, and then that's where our skill is coming from. And then we are doing neuro interventions. I mean, even intracranial stenting and neurovascular rescue procedures. And this is something what is not to train the people without giving them a possibility to make a lot of experience with cerebral angio it's a hard thing to do, and you can't start with carotid stenting. Yeah. As a first procedure, and that's a problem. You're training them on below the knee or something like this, and then you have to switch to the brain, and that's really a problem.
Yes, I would agree with that. There's a number of publications now on the learning curve associated with carotid artery stenting, and depending on whether you believe the American data or the European data, it could take several hundred patients before you achieve an event rate that's acceptable by American Heart Association guidelines. So the question is, and you mentioned this in your debate, Mark, that learning curve is a relevant consideration for the randomized trials that have come and gone. How do we actually reduce that or blunt the learning curve without practicing on patients?
If I'm the one to answer that, but as you mentioned, of course it's a problem. We lost the learning experience from diagnostic angiograms, but there are modern ways in surgery and in all techniques with simulations that will not give you the sufficient experience, but at least it will give you some idea on how the procedure goes. There should be dedicated training programs, because you cannot start from one day to another and say, okay, now today I will do my first carotid artery stenting. We could do that 15 years ago, but nowadays that will not be accepted anymore. So we should develop training programs. Now for the younger people, that's not too difficult, because they can be trained in an appropriate way. But the people who want to change their strategy and pick up a new technique, that's something different. It takes a while before you've done 50 to 75 carotid artery stentings under tutorship. That is virtually impossible.
Yes.
So we need, if we really want to do this, then we have to come up with sophisticated training.
Yeah, I agree. I mean, I don't think the learning curve is excessively long for a complex intervention, and I think it can be blunted with dedicated training programs that possibly include simulation, scoring systems that direct the novice towards less difficult anatomies and all the rest of it. And the literature actually suggests that for carotid endarterectomy, you can't be confident in the results in terms of the confidence intervals until that operator has done about 200. Then you know what their event rate actually is. And it's arguably as complex, if not more complex, than carotid endarterectomy. John, you must have fellows. How do you let them loose on carotid stenting, and how do you do that?
No, I think the TVAR and the carotid stents are the last things that they get to. But I think there's a lot of ways to train people in the skill sets that are involved in carotid stenting. For example, if you're doing endarterectomy under local anesthetic, you get a very good appreciation of subtle acute ischemic changes where the patients are yawning or confused or anxious, and you know how to react to that urgently. I think if you do, it was mentioned below the knee intervention, you can get a concept of using a long sheath and being able to handle a rotating hemostatic valve and having the direction of your intervention not be the same as the image. I think protection devices are used by cardiologists routinely in saphenous vein grafting and by some peripheral interventionalists in the renals and below the knee. So there are skill sets that you can learn that are components of carotid stenting. I don't think all of it is done on a simulator.
Okay, let's just move that forward, that concept of learning curve forward and how that sits within the randomized trials. Michael, can I ask you about your attitude towards the generalizability of CREST based on the fact that many people would argue that the operators within that trial were experts at carotid artery stenting?
I think you can establish that argument not only towards CREST, but maybe we'll get to this later on in the hour, but this concept of achieving low complication rates with best medical therapy. So I think it's right. In a trial like CREST, it's only responsible if you're trying an established therapy versus a quote-unquote new therapy to have those who are expert assess that. And once you prove that that technology or that therapy has a role to play, then it's the responsibility of the medical community to figure out how to generalize that out to the community. So actually I'm fine with having high-level experts with lots of experience in what's considered to be an important clinical trial. But I would push back somewhat firm on the fact that although I'm not an interventionist, there's very little literature that talks about specific medical therapies and their role to play in patients with high-grade asymptomatic carotid disease. Now, probably the best, most recent is Allison's 10-year ACST data, showing you that statin or lipid-lowering therapy had a tremendous impact in those patients before an event to lower complication rates. But I would go as far as to say that there's nothing out there that compares optimal medical therapy of individual types, so different angiotensin receptor blockers, different categories of beta blockers, dual antiplatelet therapy versus single-agent antiplatelet therapy in primary treatment of patients with asymptomatic high-grade carotid disease. So let's be careful that what Ann Abbott published saying that you can get complication rates with optimal medical therapy of 0.5% per year is just unrealistic in real world. So you only have to look at one thing, the NHANES data. So every time the NHANES data comes out and it updates how good doctors are at treating blood pressure, cholesterol, tobacco cessation, and diabetes, every time, in the best of situations, a third of the patients are at established goal at a year. 1/3. There's no way that's going to translate to 0.5% stroke risk per year.
Sure. Let me just compare and contrast what you said about the CREST operator experience, point 1, and then we'll go on to the medical therapy, with the ICSS attitude. And the principal investigator of ICSS was of the opinion that he was very comfortable comparing a wide range of expertise in the carotid stenting limb against really an established practice in endarterectomy, because he wanted it to be more generalizable. I'm going to put that to you, Alison, and ACST2, and the attitude of ACST2 to operator experience. And then if you could just take Michael Jack's comments forwards about current best medical therapy and what that actually means and whether you can define it for us.
Well, one of the reasons why we didn't do a 3-arm trial is because, firstly, we reckon patients were reasonably well treated between 1993 and 2008. And in fact, it was suggested that this was ancient medical treatment, but I think we showed that it was actually reasonably good medical treatment. The one thing we didn't know was the dose of statins that people were taking when they were taking it. However, an interesting comparison that we had at the time was the Sparkle data, which compared really industrial doses of atorvastatin with placebo, something that still, cannot be done any longer. And what they found was about a 1/3 reduction in overall stroke risk. And actually what we found overall was that 1/3 reduction as well. But we still find also that the absolute risk reduction by intervention was important. And, it seems to make some sense, because how can you have a world where people who are all asymptomatic can be treated so that none of them ever become symptomatic? It just doesn't happen. If you take a very short-term view, 1 or 2 years, then sure, there's not much happening. But if you take a 10-year view, then there is a cumulative stroke risk, and there is no good way of identifying who in those people is actually going to develop that stroke, and certainly not by the specific stenosis. Because even if you look a little bit closer at our data, there are some wide confidence intervals, but actually 60, 70, 80, 90% stenosis with no symptoms, they seem to have a pretty much the same risk, which can be reduced by endarterectomy. And that really fits in with cardiac data rather than anything else, because specific stenosis is difficult to relate to risk. And that's a very long way of answering part of your question. The other one was about experience.
Yes.
And experience, yes, experience in ACST2 is much, much greater than in ICSS, EVA 3S, and obviously not as great as in CREST. So somehow or other we are trying to tread a more real-life way of finding out what the real-life comparison might be. We don't quite think that we've got, or indeed might ever get to the rate where people are as experienced doing stents as they are doing endarterectomies, but we will do our best to be as inclusive as possible. So, where people have reasonably good experience, we want them to be in the trial, and we really want to have them, and we're very open to more centres. Is that...
Yes, thanks, Alison. I'd really like to engage the audience. Do you have any questions on operator experience, current best medical therapy, or how to advance carotid stenting at all? Can I ask how many of you perform carotid stenting? You put your hands up. And that's okay. It's just less than 50% of the room. And how many of you learnt on patients? How many? Yes. Everyone that's doing carotid stenting. So did any of you have access to simulators or structured training programs for stenting? So did you all learn directly from a tutor, a senior physician in your unit?
Self-taught.
Self-taught? If you want to take that forwards, John, you volunteered. So no questions from the audience on operator experience? How we can reduce that? Okay. Well,
I have one question,
Yeah.
maybe for Allison or Michael. The U.S. regulatory trials were all, for carotid stenting, were focused on the asymptomatic patients 80 to 99%. I'm not really sure why they got started that way, but I have a feeling it had to do with people thought maybe if you take the more severe degrees of stenosis, it makes more sense, it's indicated. My understanding is both ACAS and ACST have shown that 60 to 80% asymptomatic stenosis is perhaps even higher risk for stroke than the subtotal occlusion. Henry Barnett in his editorial to your said, I don't believe that, I don't believe the whole trial, but is there an explanation for that, and is that a real finding?
Well, I mean, of course, I don't have an explanation for exactly why that is the way it was, but I mean, all we could say is that what we took was people who were considered to be worth thinking about intervention in. So they were not the people that you were going to keep aside and just treat medically. And that's how it turned out, that they seemed to have similar risks if they had a significant stenosis. I don't know what the findings would be if you took people with 50% or 40% stenosis, but I guess there may be some relationship. Michael might know that.
Well, John, I think the guess here, and that's all that is the correlation to the coronary literature with hot or vulnerable plaque, which oftentimes look just 30 to 40 to 50% on an arteriogram, yet they're the most dangerous. Whereas a more critical stenosis has a time to become more fibrotic and organized, and so its embologenic potential becomes lower. And as you know, the hemodynamic risk of a stroke from a tight carotid stenosis isn't really that big a deal. So I suspect that that's the rationale for why a mid-range 60 to 80% would be potentially hotter and more embologenic than a 90+% stenosis. That'd be my guess.
can we just go back to best medical therapy, the concept of best medical therapy and its inclusion in 3-arm trials in an asymptomatic population? And basically my question to you, Michael, is how difficult do you think it is to run a 3-arm trial?
Well, I think it's really hard. I love the concept of best medical therapy versus best medical therapy and best revascularization. That to me makes the most sense. As we heard from several discussants this morning, allowing a physician who's got the capability to do either carotid stenting or carotid endarterectomy to individualize the option per patient makes the most sense to me. Now, what defines optimal medical therapy? I think it's really a crapshoot based on what we think is best atherosclerosis therapy, and hope that that translates well to carotid artery disease. And you know, one of the comments I heard this morning, which I obviously didn't have time to debate, was this concept of using dual antiplatelet therapy in patients following carotid endarterectomy. With all due respect to Dr. Naylor, the literature on that is miserably poor, and I understand that some people like Tony Comarada think that might explain in CREST the disadvantage of the MI risk in patients. But, you know, if you look at all the literature in coronary disease, not using drug-eluting stents, dual antiplatelet therapy has no preventive effect in future MI or events. So I'm not convinced that that's going to have a big role to play. If I could just ask John one question. John, as you were talking about being self-trained, which I suspect is somewhat true, when you train somebody else who doesn't have a lot of catheter-based experience, what's the hardest part of the procedure? I mean, I'm asking this a little tongue-in-cheek, but is the hardest part placing the embolic protection device and doing the dilatation and placing the stent? Is the hardest part getting from the groin to the ostium of the common carotid? What's the hardest part?
It's different for different students, and I will say that I've had people who I've come to train where I've taken them aside and said, I really don't think you're ready to do this. So if the let's just be stereotypical. If it's a general surgeon or cardiac surgeon or vascular surgeon who doesn't even do EVAR comes in to do carotid stenting and they cannot pin the wire in the simulator to advance the balloon, after a little while you take them aside and you say, why don't you just watch and start doing angiography and filters and EVAR first. But I would say for the advanced operator, it's the cognitive skill to select the patients that shouldn't be stented, and it's the ability to rapidly troubleshoot neurologic complications when they occur, when there's still a chance to salvage them. Those are the two things which people who have the skills, who can do a lot of other things in the body but haven't done carotids, having them learn that is, I think, the big hurdle. Most people can deploy a stent, deploy a filter, retrieve one, put a sheath in. I think that's not difficult.
Mark, do you want to comment on that?
Yes, I want to make a remark about the dual antiplatelet therapy. With respect to neurological symptoms, the literature is crap. With respect to ischemic heart symptoms, the literature is not so crap at all. We know from the CURE trial that patient with acute coronary syndrome has a clear advantage of dual antiplatelet treatment for at least for a year. Now, if we're looking at patients with asymptomatic acute coronary symptoms, these are the patients that have an enzyme elevation. There are indicators that these patients should be treated with the dual antiplatelet therapy also. This is a study that we're running in the Netherlands, and we will get the results later on. Now, there are also indicators that patients who are at higher cardiac risk for any surgery at all, whether it's GE or vascular, that these patients should be treated preoperatively with dual platelet therapy to prevent coronary events. So that's this thing in CREST. It might be a chemical difference in myocardial infarction, not the treatment at all. It might be chemical. The other thing is that what CREST is showing that patients with MI or asymptomatic enzyme elevation have a worse outcome. That is because these patients are not treated properly. If you treat these patients properly after an event, acute coronary syndrome, asymptomatic acute coronary syndrome, their life expectancy significantly increase. So now you could also argue that the patients who have a TROP-T elevation after carotid endarterectomy, if you start treating them with dual platelet antitherapy, if you don't want to do it preoperatively, that we will improve their life expectancy and that the effect of a myocardial infarction, which is shown in the CREST trial, might not be so predominant as been shown in data from 2003, where we didn't have dual platelet antitherapy at all. So the slide that was shown this morning is not a real valid slide for the expectancy for patients with myocardial infarction. So we should be doing better. We should, if we want to treat this patient, we should focus on coronary events, not necessarily on the neurological events.
That's a fairly controversial comment. It tends to suggest that you think that the patients that suffered periprocedural MI and CREST were just left to languish following an MI and not treated at all. And I'd like to take
I'm not saying in CREST, because
that.
CREST is not showing the long-term effect of these patients with cardiac events. But the slide that was showing with the prognosis of the patients with cardiovascular events was old, and so the expectancy was without dual antiplatelet therapy.
Yeah, and without statins, in fact, because 2003 very few people were on them. But actually, of course, it's all about the long-term outcome, really, really long-term outcome. Yeah. So, I mean, if you look at people who were having events and their outcomes in symptomatic trials 20 years ago, they're dying of the same diseases. They were dying quicker of them then, but they seem to be dying, the same proportion of them, of the same causes, just a lot longer. So we're talking about lifespan and the value of treatment during a lifespan. So, and I entirely agree with Mike when we're talking about the Anne Abbott data. What you're looking at there in that spectacular, it's actually a combination of Anne and Peter Rothwell, I think, putting together the other arm or the other side or the other group of people in whom nobody intended to operate, and looking at what happened to that. And what you're seeing from that is effective better medical treatment, but it's still short term.
Can I just go back temporarily to the three-armed trial concept, especially to you, Klaus, because you've got Space 2 running, and I understand that they're struggling to recruit. Could you
I think there is
us?
a psychological barrier for the patient, yes. When you have the patient and you need naturally, before you enroll him, to inform him what is going on. And he's referred to you because he has a stenosis, so he expects they will remove the stenosis. Then you tell them, oh, we have not the evidence, because you are asymptomatic, that you have a benefit from carotid endarterectomy more than from medical treatment or carotid artery stenting. Then he has three options, and it's very difficult for the patient to decide what will be the best for me. Yes, when he is referred to the surgeon, he expects that he is operated. When the surgeon tells him, oh, perhaps it's equal when you only take some pills, he's confused. And I think that it's really stressful for the patient to make the decision at the end, even when you try to inform him in a very neutral manner. At the end, with these three options, yes, and the same is when he's referred to me. I tell them, oh, you can also be operated. He will tell me, no, I come to you not to be operated on. So that's the reason why enrollment is going very, very slowly. And I doubt that I will live long enough to have the end result of this trial. The idea, theoretically, is very good, yes, but practically, it's a problem, and I think the problem is in the patient, yes, or you have a very stupid one, then it's easy. But the more intellectual one, they will have their doubts, and at the end, they will go away and go to another physician and tell them, oh, I don't want to be treated within the trial. I'm not a rabbit. Can you not offer me a service, and so you will lose the patient at the end?
But Klaus, it's to do with the doctor that has the patient in front of them, isn't it? Because in this instance, in German-speaking countries, one assumes that the doctor offering them that trial is in fact the neurologist. So they haven't had any symptoms. They have got a stenosis, and the neurologist is there. But I entirely agree, because I cannot imagine as a surgeon a patient sitting in front of me and me saying, well, look, there's something that 80% of me thinks you should have something done about, and 20% of me thinks you shouldn't. I mean, that's a really indecisive surgeon that you'd be sitting in front of. I need to be convinced that there's not much difference between something before I actually do that, which means also that Space 2 is probably selecting out people with, less dangerous, in inverted commas, or thought to be less dangerous lesions.
Can I just make a comment on that also? I understand that part of the problem in Germany, and it's Germany, Austria and Switzerland, isn't it, Space 2?
Everybody can participate in the trial, yes, when he fulfills the minimal requirements for that. But I pointed out, because that is the main reason, I think, why this trial is not running so well. It was quite different, because you mentioned the neurologist. The neurologist was involved in the symptomatic patient, because when you have a TIA or a minor stroke, you are referred normally to a neurological department. So the enrollment into the trial was very easy. The randomization was done by the neurologist. That's with the asymptomatic patients, it's quite different, because it's incidentally found, you have a carotid artery stenosis that can be found by the cardiologist, by some other internal medicine people. It can be. Normally, you're not referred to a neurologist. Also, they will find from time to time stenosis, but that is not the primary aim. The patient will not go without any symptoms to a neurologist.
I think also part of the problem is the reimbursement issues, and I understand, you can correct me if I'm wrong, that in Germany that there is a different tariff or reimbursement associated with the medical treatment of an asymptomatic carotid stenosis and something wholly higher in terms of reimbursement when a patient receives a stent or an endarterectomy, that's a disincentive to put anybody in a 3-arm trial.
I don't think so, because that is the money paid to the hospital when you do a surgery or an intervention. So in the German system, it's not that the physician will earn more money, so it's not money driven in that sense. And we get about 4,000 euro for a carotid artery surgery as well as for carotid artery stenting. So that's nearly equal. The difference is 150 or 180 euros, so that doesn't matter. And yes, medication, that's a question who is to pay for that, yes, because we have some limitation for the private practice physicians. They have a budget, and when they go about the budget with their medication, yes, then they are responsible for that. So that is, yes, something characteristic for the German system. It might not be the same in other countries.
Can I just ask the audience how many of you would be interested in joining a trial of intervention versus best medical therapy or various interventions? No, as an operator. For an asymptomatic population, how many of you are currently enrolling into trials? Yeah. How many would be interested who aren't? Come and see Alison at the end. Can I just ask you, John, it was you were responding to one of Michael's comments about which do you think is a rate-limiting step in carotid artery stenting? To my mind, it's the catheterization. The rate-limiting step is secure access to the carotid artery, and once you've got there, the rest of the procedure progresses in a fairly seamless fashion. And if we go back to look at the timeline of DWI lesions, recent data from Pete Gaines in Sheffield show quite clearly that at 24 hours, and you know that MRI, DWI, is very sensitive to acute injury within about 30 minutes, there were far, far more lesions at 24 hours than at 1 to 3 hours post, and they were ipsilateral and contralateral. It does tend to implicate dislodgement at the arch level or ostia of the great vessel. So can you comment on access difficulties and whether you think that an alternative access site might be better for the patient and easier for the operator?
Sure. I just want to make sure if anybody has a question out there, just stand up because we keep asking ourselves questions. But I think that in 2005, in that era when carotid stenting just rolled out in the U.S., getting the sheath in position was clearly a major teaching feature and the major hurdle for a lot of the interventionalists. But I think that subsequently people have done a lot of up and over catheterization for below the knee. Very comfortable now with the longer sheaths, exchange techniques, as well as telescoping techniques. And the equipment, frankly, has improved. You know, the Shuttle Select, the different types of carotid sheaths and catheters or guides that are out there, I think, have improved. So it's not as big a feature, I think, as much as, or maybe I'm imposing my own bias on my students, where I want them to know what they shouldn't try to do. Knowing what anatomy is not really suitable for carotid stenting. And I think at the same time, a lot of people have taken the selective catheterizations and the sheath placement and either put a time limit on themselves or have said, you know, there's a certain point where I'm just too nervous about scratching at the arch and I'm going to abandon this. So maybe we've all learned that, and so that's why it's not as much a focus of the teaching.
Michael, you're as close as we get to a neurologist on this panel.
Don't insult me.
Please, neurologists out there, comment on this. There is a difference in favour of endarterectomy with respect to minor stroke that's often a post-procedural event, i.e. day 1 to day 30. It's not on table in experienced hands. And we know that there's an excess of DWI lesions for stenting. And to my mind, these two things need to be addressed to advance carotid artery stenting. Can you tell me what the relevance, the clinical relevance, and the fate of DWI lesions is?
No. I can't. I think it's a debated issue, and it's one that, in order to answer appropriately, is going to have to be a prospective endpoint of some trial to determine it, right? So you're going to have to do DWI imaging on a whole bunch of patients prospectively and compare that with a high-level objective assessment of mental status to pick out subtle changes and see if it really matters.
Alison?
Yeah, I mean, we would certainly like to have that within our trial. However, it's so sensational because it added so much to the ICSS results that it was a bit like describing a cerebral protection device. It tells you it does something, but you're not actually sure whether it's true. So in a way, DWI images that tell you that there's something wrong, but actually they don't tell you whether there's something relevant about it. So if it's within ACST2, I think it should be clearly done, and it should be presented with the final results with decent follow-up. And, long-term follow-up probably means 5 to 10 years. The significance of it in terms of any differences between two arms, dementia frequency is going to be very difficult to prove. So I think it's a hint that somebody thinks there's something wrong. It's a prejudice, but there isn't actually any evidence.
Klaus.
We have, on the opposite, we have some trials showing or testing the cognitive functions, and they show that the cognitive function has improved and not worsened. So that I have the impression that at least when it's not a large amount, but we have only 2 or 3 white dots, that it doesn't matter. Certainly that is because you have a diffusion impairment there, that is cell death, so you are losing some cells. But I think that doesn't matter, it's not enough. And the cognitive function improves because you have perhaps many patients will tell you also that they feel more vivid, that they can remember better afterwards, because we have a normal perfusion of our brain tissue. There's about 70 millimeters per 100 gram of tissue and minute, and you have a stroke when it's less than 20, and something between 20 and 70 happens. So the brain function certainly is also better, because nature will not establish 70 when it's not an optimum.
I'd have to say that,
so
that's an emotional argument, isn't it? I mean, you are undoubtedly biased in favor of intervention. So,
no, I think that
whenever
it's
I
better
do
to have
an
a patent artery
endarterectomy,
than not a patent artery.
But
we are now treating to prevent stroke and not to improve cognitive function. That's a different motive, naturally, for treating, but that is a side effect.
It's terribly
the brain
anecdotal,
is working
isn't it?
better when it's normally perfused.
It's terribly anecdotal, but I find that usually it's the husband or the wife of the person I've just intervened on that's saying, she's looking so much brighter, John, I know you've got something to say here.
Yeah, I have some comments. I think Tony Camarado asked this question. I don't see him here, but that we know that DW infarcts cannot be good.
Sure.
Right?
Sure.
And we know that, same with hits, it just can't be a good thing to have that. The question is, what degree does that correlate to a clinical endpoint, or what degree does it correlate to some clinical endpoint we aren't measuring now that's bad, like neurocognitive testing? At UW, we have an R01 grant to look at neurocognitive testing in the most sophisticated methods, as well as MR infarcts before and after any type of carotid revascularization. But I think it's a fantastic tool, as Allison said. We have troponin, and we have these screening for subclinical MIs, and we could argue whether they do or don't predict late outcomes, but it's nice that we actually have something. I just wish it wasn't so expensive, and we could put it into more clinical trials. If we could find maybe the TCD or maybe something else that's a little less expensive than an MR pre and post, then we'd use it in a lot of these carotid trials. I think we could have a lot better power to detect between stent cells and embolic protection, yes, no, reverse, antegrade, whatever. So I'm looking forward to seeing more studies on it. Just we need a cheap magnet.
Yeah, I'm not convinced that we know the clinical relevance and fate of these lesions at all with any degree of certainty. But to my mind, intuitively, if there are techniques and procedures that reduce that microembolic burden, then why wouldn't you do that? Because surely they can't be good. Surely they can't be good. Mark, I know you have something to say.
Yes, about the neuropsychological testing, what Klaus is referring to, that was observed only in a very small percentage of the patients, so that was not a general trend. And we should not forget that the neuropsychological testing is not a very validated technique. The outcome is influenced by many factors, whether the sun shines or whether it's raining or whether the patient slept well or not. That can influence the outcome of neuropsychological testing. So we have these outcomes that are proclaimed are not validated at all.
Can we just go back to the comment that I made about the difference in favour of endarterectomy based on minor stroke, which is generally off-table, and tends to, if we look at the CREST data, certainly resolve in terms of modified Rankin scale and NIH stroke scale. Michael, do you think that we can implicate the stent in its design, or do we need better drugs? How are we going to reduce further that off-table minor event rate for stenting?
So this goes into the subject of cell size, and if you use your imagination and think that you have a very inflamed hot plaque, and you have an open cell design, and you place a stent that until it endothelializes has a tendency to shift even a little bit, that it could scissor some of this plaque and cause emboli, to cause peri-procedural events, out to 72 hours or something like that. It's a tantalizing hypothesis. I think it's a hard thing to prove.
Sure.
So then the question is, what post-procedure management strategies can you use to lower that risk even further, which I think is what you're driving at.
Yes.
Is there an advantage to using, huge doses of statins 4 weeks prior to doing an intervention if you have the luxury of time to do that? There's endarterectomy data in small series that showed that you change completely the morphology of plaque when you pre-treat for about 4 weeks with a statin. That showed with matrix metalloproteinase production. It actually was sophisticated plaque analysis of the endarterectomy sample afterwards. That'd be a nice thing. Unfortunately, lots of these patients you don't have 4 weeks to pre-treat them or 3 months. But that's one possibility. Another one that I think you can't discount is the role of angiotensin-converting enzyme inhibitors and ARBs. I think these are agents that have a lot of vascular protection that go beyond just blood pressure. I think these are not myths anymore. They're well established and ought to be considered as first-line therapies for patients if you have a reason to use them. But I think that's going to be where the game's ended, because to make the case that every stent should have a closed cell design to protect this, I think is going to be hard to prove.
Sure, it would be very hard to prove, given the current event rate. I mean, to adequately power such a trial would be eye-wateringly huge. But, I mean, that's exactly consistent with Pierre-Georges Cow's recent work on the protective effect of statins in carotid stenting. There's a question here.
Thank you. Just to be clarified, I would like to ask a couple of questions to a neurologist here with us.
Yeah. Look what you've done.
So, would you screen your carotids right now?
So, are you asking me that emotionally or population-based?
Emotional, yourself, your idea. And would you screen your carotids?
I think if patients have certain atherosclerotic risk factors.
No. Yourself.
Oh, my personal.
Yeah.
I've already done that a million times.
With other men. Okay.
Oh, yeah.
So
I run a vascular lab. I'm holding the probe anyway. What's the big deal?
And then what if you have ended up having a 70% stenosis by chance? What would you do? And to yourself?
An asymptomatic 70% stenosis in myself. What would I do? I'd likely go on very high dose potent statin therapy, a single antiplatelet agent, and an angiotensin receptor blocker.
For how long?
I'd do it for the rest of my life.
Okay,
Now, if I had diabetes, I'd aggressively control it, even though that's probably the risk factor that's got the least evidence that it's protective, but I'd do that too. If I smoked, I'd shoot myself because it's impossible to stop smoking.
Would you come get an opinion from Klaus or Mark?
Yes, certainly I can spin on that. So what is when you don't tolerate the statins?
Yeah. So
what would you do then?
So I'd switch to a different class of statin. If that didn't work, I'd go to a different lipid-lowering agent entirely.
There's a question at the back.
Yeah. There is several reports, especially in cardiology, addressing clopidogrel or aspirin resistance about up to 50%. And I think that this factor has not been taken under consideration in the most trials. And I would like to ask your opinion about it.
Is that you again, Michael?
Resistance, non-responders.
So this is a very big deal. I actually am concerned about this. I don't know about from carotid disease. Maybe I should be more concerned about it, but certainly I think there's clinical relevance to this. The challenge, at least in the United States, is that these assays that are available on the spot to check for them continue to evolve. They're not inexpensive. The implications for testing everybody for aspirin and clopidogrel resistance becomes, at least in our current healthcare system, cost prohibitive. So I don't know where this is going to play, but I could not agree more that this is a risk factor that's not well discussed and is important.
We've got some questions here.
Yeah.
Go ahead.
I follow the same politic when I find an asymptomatic carotid stenosis. First, I start with aggressive medical treatment, and I do the follow-up with duplex scan. And if I find in the follow-up an increase in the stenosis, for example, from 70 to 80, 90%, I do perform an operation. Do you think this is do you think this is the right thing, or would you follow with the medical treatment?
How come you put me on the spot like this? So I think that if in a relatively short time frame, let's say over the course of a year or 2 years, you see clear progression of a stenosis from whatever your lab goes from one category to the next, and the patient understands the risks associated with any alternative therapy, then I think it's worthwhile having that discussion. But it really goes back to that issue of individualizing what the patient wants. There are some patients who John knows this very well, who say, I can't live with that stenosis in my neck, that aneurysm in my belly. They just can't live with the fear of that. There are others who are willing to do whatever they can to avoid at all costs any invasive procedure, and to try and lump them all together is just impractical. So.
But I think it's potentially a bit dishonest, isn't it, to say to the patient, come back next year and have another scan, because what you're leaving them with is the idea that you are protecting them from an event which you can't predict, and which next year's scan is actually not terribly good at predicting either. I'm not advocating that you intervene in them. I'm just saying that what you're giving them is a false confidence in a test and a time that actually is not real. There isn't really good evidence. I mean, we have tried looking at that because we followed people every year, thousands of people every year in ACST1, and only a really pretty small proportion of them would be picked up by having progressive stenosis. So we couldn't confidently say to 7 or 8 out of 10 of them that it was going to make a difference. It's a pity, but it would be nice if it did.
Yeah, but what are you going to do? I mean, in reality, what are you going to do? I mean, when you have these patients who are found to have, in our lab, we have our criteria that we call over 70% stenosis, and the patient and you decide that you're not going to intervene, but you're going to initiate therapy that wasn't currently being used in that patient. So you're doing something that you think is helpful. Is your answer then come back if you have a loss of vision in an eye? I mean, you got to do something, right?
Well, I mean, what I meant is clearly you've got to explain your own lack of confidence in a way in a serial test. So you've got to say, this test may be valuable for a few people. Currently, your risk of having a stroke on medical therapy is this. It is possible that a few people may have a stroke during this time, but it is certainly possible that sequential testing may not pick that up. And I think you have to be honest about it.
John.
I'll be the American interventionalist who's salivating right now. I think 95% of the patients are like Michael or your patient. They're not scared of intervention. They're not scared of stroke where they're going to make a decision. And they rely on the physician to provide advice for them. And I think if both of you are less than 75, your patient's less than 75, reasonable life expectancy, I will offer both your patient and Michael an operation and a stent, because with the caveat that the risk reductions are small, but they're statistically present, and I think that about 2/3 of patients actually will accept that advice. About 1/3 do what your patient's done and say, I'll go just with the medicine, and if there's symptoms, I'm coming to you. when they get progression, they do worry more. But if it's 70%, I'm already worried about that patient. They're in that range where I will recommend an intervention.
Do we have a question?
I think things change with best medical treatment, which also changed a lot last decade. And I think we are not in a position, if you look at the number need to treat to prevent a stroke in asymptomatic patient with best medical treatment, it is not in real world, you don't reach, you have to be honest and say the risk of intervention, yes, in a real life, it's not justified for asymptomatic patient. If you can offer him best medical treatment, there is no place for surgery and no place for stenting.
I can see you twitching
Yes.
here, Alison.
At 10 years, which is what we were trying to put in our results, at 10 years, if roughly 10% of people have a stroke, that's 1 in 10 in 10 years, then you're comparing it with 1 in 15. And that's what you need to tell the patient, surely, because it's slightly more extreme in the under 75s. They're the ones that really have got that risk built in there. So if they're young, you can say, if you have something done, you have a 1 in 10 risk, roughly, over the next 10 years, compared to 1 in 15. So it's a 5% difference. The patient will say, well, what difference does that make to me? They have to think about it. You have to treat them medically as well as you can, but they have to think about it. And as Michael says, there are a proportion of younger people who not unreasonably can't live with the sword of Damocles hanging over them. They want to fix something. And then if you have reasonable alternatives for fixing it and they understand the risks of fixing it, that's a choice they have to make, isn't it? So, you can't abolish the risk just with medical treatment.
You have a question?
Yes, thank you. I want to ask if I am doing the right thing. In my clinical practice, we use dual therapy. And it's not just, I'm a surgeon, but I do also cast. But it's my fellow cardiologists that they already have this patient because they have the PCI or bypass, and they are already in dual therapy. And what I have noticed recently is that patients that I've been following with 70% stenosis or 80%, that have remained stable. I don't operate in as much as I used to be. Am I doing something wrong, or what's going on?
That's the reason why we have trials.
You're not going to try and convince me that dual antiplatelet therapy prevents progression of carotid atherosclerosis, right? That's for sure. So the most likely combination will be statins and an ACE inhibitor, or some angiotensin receptor antagonist, in my view. I think those are going to have great impact.
We have a few minutes left. Do you have any questions at this point? I'm just going to put a question to each of the panelists, starting with you, Mark. Do you think we need further trials involving carotid artery stenting? Yes or no, and what sort?
Yes, we do, but the design of the assessment of the patient should be different. Not comparing 50% of the patients stenting, 50% of the patient endarterectomy. That will not give us any answers. Only with sub-analysis in these trials.
John?
Yeah, well, I'm biased because I'm running one of those, but I think on the background of optimal medical therapy, comparing stenting with routine embolic protection in trained hands, with endarterectomy, with routine patching, systemic heparin in trained hands, with a 5-year follow-up was one question. I think SPACE 2 should be supported if the enrollment can increase. I think there's enough what I call equipoise among doctors, that is the neurology community, I think is convinced that maximal medical therapy is an alternative to intervention for asymptomatic patients, as we've heard today. That should be supported. But I think we also need to continue to improve the technologies of intervention, just like we probably should be doing with medical therapy, as Michael said. We should be looking at patients. I don't want to know if Crestor 80 compared to, or Lipitor 80 compared to 20. I want to know 80 versus 40 or 80 versus 20. I don't want to know 80 versus 0, as somebody mentioned there. And I want to know flow reversal versus distal filter. I want to know closed cell, open cell. And I think we can use the surrogates for those studies. We can use DIMR, infarcts, or whatever else you want to use.
Klaus?
It's very difficult to add something sensible and reasonable after that comments. Yes, so I'm certain we need it. We also should use registries. with good data, because all the trials have exclusion criteria, so you never know the whole truth, what is going on with the patients. That's the advantage of registries, because all the patients are included. And as already mentioned, yes, I think we need the trials, because there's quite a lot of open questions where we have no answers.
Alison, you're going to say yes, of course, come and join mine.
Well, no, I mean, we actually, just as far as what Klaus said was concerned, we have very, very wide entry criteria. That's why we try to get a generalizable result. So we are saying there is no age limit, despite the results from ACST1. If you feel that this patient is right to put in the trial, put them in. It is terribly important if you start subgroup analysis with surrogate endpoints to recognize exactly what you are doing, because you are getting an answer to a question that you have a prejudice about. And it's not realistic to do subgroup analysis on less than 1,000 patients in each arm, really, to get a definite result. So if you want a simple result, get a big trial.
Michael.
You guys will all figure out this carotid stent versus endarterectomy thing. I have complete confidence in you. Somebody needs to do the trial where the medical therapy arm is doing it like a real medical therapy trial, where you do compliance rates and pill counts, where you do assessments of goal, how many patients actually achieve their medical therapy goal, how long are they compliant for, et cetera. Then you'll convince me once and for all the role of medical therapy.
Thank you. I'd like to thank the panellists. I'd like to thank you all for your interest and your attention, and I think it's now time for coffee.
That's a natural